My name is Christine Pillay, and I am a member of the SAMED Market Access Committee, and it's a pleasure to welcome you to today's forum. Thank you for joining and making time, and we know that everyone's diaries are quite stretched, and there's a lot of demands in the operating environments, which makes today's discussion very, very important and critical. As the market access processes is tightening within the country, funding pressures, procurement for reforms, evolving HTA requirements, and affordability constraints are reshaping how medical devices or medical technologies are evaluated, reimbursed, and contracted. So if we are not informed, we will be reactive. If we are not prepared, we will be excluded. So today's forum brings together regulators, funders, procurement leaders, and HTA experts to equip you with the intelligence and readiness required to compete in South Africa's market. Before we start, a few housekeeping rules and just a reminder. This session is being recorded for minute-taking purposes. By participating, you consent to the recording. Please declare any conflicts of interest and excuse yourself where necessary. This meeting is conducted in full compliance within the competition law. Please avoid discussing commercially sensitive information, including pricing, costing, supply terms, strategies, and distribution agreements. And this applies before, during, and after the SAMED meeting. If you believe an improper discussion is taking place, please raise this concern immediately. We encourage engagement, so please use the chat or Q&A functions to submit your questions, and we will take questions after each presentation. So let's begin. Our program for today, and the first topic would be Behind the Numbers, Key Insights and Trends from the latest Council of Medical Schemes Industry Report. Then we'll move on to Demystifying Life Healthcare's Procurement Process. Then next would be your MedScheme Health Policy Unit MedTech HTA Update. And lastly, we would end with a pre-launch of the HTA webinar series. So moving on to our first topic, which is Behind the Numbers, Key Insights and Trends from the latest CMS Industry Report. Our first speaker is Kerry-Ann Cairncross. She is a seasonal data analytics and research professional with over 16 years of experience. She currently serves as a senior researcher at the Council of Medical Schemes, where she leads critical projects including healthcare utilization, statutory returns, scheme risk measurements, and chronic disease prevalence within medical schemes. Her work sits at the heart of how medical schemes understand utilization, risk, affordability, and sustainability. Today, she will help us interpret what the latest CMS industry data is telling us, not just statistically, but also strategically. Specifically, we'll explore key data trends impacting funding, utilization, and affordability, policy and regulatory signals shaping scheme behaviors, what these insights mean for medtech positioning and reimbursement prospects. So over to you, Kerry-Ann, and thank you for joining us.
Thank you, Christine. I'm just going to put on my camera so that everyone can have a look at see who I am. As Christine has indicated, I'm Kerry-Ann Cairncross. I'm a senior researcher at CMS, and I'm quickly going to take you through some of the insights from our industry report. Please let me know if you can see my screen. Sorry, Christine, you're muted.
We can see your screen, but are you able to put it into presentation mode?
Yes, I'm going to. Okay, I'm going to just put off my
Thank
camera
you.
so that it assists a little bit. Okay, there we go. Okay, great. So I'm going to cover some of the trends in the number of schemes operating in the industry. To you, the number of lives that we're currently covering or that we covered in 2024. What constituted benefits paid? I'm going to go into some detail on PMB expenditure. I'll highlight for you the out-of-pocket trends that we've noted in the industry, and then go through some of the utilization trends. I'll then conclude with my part of the presentation, but then I'll also answer some of the questions that I received in terms of the MedTech questions that was sent over to me. Okay. Right. So in terms of the number of medical schemes, in the last 24 years, we've seen consolidation happening in the industry, where we had about 144 schemes in the early 2000s. We currently only left with 71 schemes in 2024. And then in 2025, we've also lost another scheme where Lonmin has now merged with Sisonke Medical Scheme. So consolidation is still continuing. And what we see is that open schemes are now about 16, where restricted schemes were around 55. With Lonmin moving to Sisonke, that has obviously also decreased. And when you look at the size of these schemes, what you'll see is that large schemes consolidated as well, where we had around 40 large, sorry, I'm saying 40 large schemes. We had 40 large schemes in 2002, and that's around 21 in 2024. Where you look at small schemes, these are the ones that had the highest rate of consolidation, where we had around 76 schemes in 2002 that were small schemes. They are now currently only at around 30 schemes. And medium schemes are the ones that increased. They were around 20 medium schemes in 2002, and that has now grown to around 30. So the smaller risk pools are consolidating over time, and that's what that we see continuing in the industry. Great, and as we move over to beneficiary growth, the industry has seen very minimal growth in the last few years. Between 2023 and 2024, there was around 0.45 change in the industry, and that's a very small percentage, where we went from 9.13 million beneficiaries, and we're currently at 9.17 million beneficiaries. And what we've also seen is that the coverage in the country has also declined, which means that the population is outpacing the growth of medical scheme beneficiaries. However, if you look at the trends in beneficiaries between open and restricted schemes, you'll see that open schemes remain stable over the period, but in the last few years, we have seen a decline, where restricted schemes are the ones that's actually driving the growth that we've seen in the industry. So the open medical schemes has seen a decline, and that's evident by the last year-on-year changes, where we had 4.8 million beneficiaries in 2023 in open schemes. That decreased to 4.74 million beneficiaries. And the large growth that you see in there is largely attributable to restricted schemes having seen growth. Now, if you look at the average age of beneficiaries, beneficiaries are aging. That's purely because we're not seeing growth in the young and healthy beneficiaries. So what's happening is when we do see beneficiaries growth, it's in the older age band, so it's not in the younger age bands. And what is happening is that the beneficiaries that are on medical schemes are the ones that's aging, right? So we're not seeing a lot of growth in the young and healthy beneficiaries. So there you can see that male beneficiaries are on average 32.7 years old, and then the female beneficiaries much older at about 34.4 on average. And then we've seen some growth in the pensioner ratio as well, where pensioners are now 9.8% of the industry. Right, so when you look at beneficiary dependents, these are the number of dependents per member. And what we've seen is that there's also slow growth in dependents. We saw about growing from 2.5 million in 2023 to 2.62 million in 2024. And there again, the growth is in the restricted market, where we see that more members in the restricted market continues to enroll beneficiaries. However, we've seen a slight decline in dependents in the open medical scheme. Right, so when you look at the distribution of beneficiaries by province, these are just where is the beneficiaries lying. So, and where are we seeing growth? So the largest growth that was experienced was outside of the Republic, and these would be beneficiaries that's gone outside of the country and had to access medical scheme care, right? Then the second largest growth that was seen is for unspecified. We're not quite sure why that has happened. So that would be where the scheme wasn't able to identify, where those beneficiaries was. So that's at about 14%. And then just looking at the other growth, we saw a large decline in Mpumalanga, which is about 6.8% between the two financial years. And I think it was large increases was observed for Limpopo. So that's where beneficiaries had moved to Limpopo and access care there. And I think, as I mentioned, we only had a 0.45% growth in beneficiaries year on year. And now, so as we move over to total benefits paid increased by 8.52%. So we went from 238 billion in 2023, and that increased to 259 billion in 2024. What was the highest increase was risk benefits at 9.4%. And we saw some decline in the savings benefits paid out. So we saw a 0.27%, a slower increase, but it was an increase of 0.2%. That increased from around 23.05 billion to 23.12 billion. Okay. And so when you look at the averages paid out per average beneficiary, that's where we saw a decline in the savings benefits paid per average beneficiary. So we saw an increase of 7.84% per average beneficiary paid out in 2024. Risk benefits paid out increased by 8.71% in 2024. And then the savings benefits paid out per average beneficiary decreased by 0.36%. So when you split total benefits paid by scheme type between open and restricted, you see that benefits paid out in restricted schemes outpace that in open schemes. So total benefits paid out in the restricted schemes increased by 13.03%, and in open schemes that only increased by 5.09%. The same is for risk benefits paid, where restricted schemes had an increase of over 13% in risk benefits paid, while open schemes only saw an increase of about 9.4%. And there you see the benefits paid out decrease for savings benefits paid out in open schemes at 2.12%, but it increased in the restricted market at 9.8%. Okay, and when you look at per average beneficiary, also split at open and restricted, you see that open schemes increased by only 6.57%, while restricted schemes increased their benefits paid by 9.83%. The same increases are then observed for risk benefits paid, where open schemes only increased by 7.72% and restricted schemes increased by 9.97%. Okay, and then savings benefits paid decreased in open medical schemes, but it saw an increase in the restricted schemes. Okay, sorry, I just went back there. Okay, great. So when we look at who's those benefits paid out to, private hospitals still has the highest rate of benefits paid out. Private hospitals and specialists takes about 64% of total benefits paid out. That has increased for private hospitals on average at a 4.15% between 2005 and 2024, but the year-on-year increase was 5.08%. So that growth outpaced the average year-on-year increase as well. Specialists increased by 6.27% on average between 2005 and 2024, but the year-on-year growth was a bit dampened at only 5.23%, so it was a bit lower than the average annual increase. Medicine dispensed, the third line there, which is the dark blue line, that increased by 0.74%, which is much lower than the average annual increase of 2.65% between 2005 and 2024. And these values that's projected in this slide has been adjusted for CPI. Okay, so when we look at hospital reimbursement methods, these are the methods that is most prevalent in the reimbursement in hospital services. And what we see is that fee-for-service is still predominantly the method used in the industry. We have seen some changes in the per diem taking place, where it went from 6.38 billion to 6.63 billion in 2024. Global fees and uniform patient fees that we see in the provincial or state hospitals has actually seen very small changes. So you can see global fees seems like it had stayed the same, and the uniform patient fee has increased by only 0.02%, or it's increased to 0.29 billion. So when we look at medicines dispensed, these are all taken out of our industry report, so you're welcome to then access this as well. You see that the largest payout is still in terms of medicines going to pharmacies. And then the second there would be general practice. Those are dispensing providers, and then clinical services. And as you go down the line, you'll see that that decreases for provider group or provider types. Okay. Other has been excluded in this graph, but this is just some of the top 11 medicine dispense providers when you look at total benefits paid to for medicines. Okay, so when you look at benefits paid out per age groups, this is where we see that proportionally more benefits are paid to older age band beneficiaries, and that's due to aging, where the older you get, the more healthcare you consume. So the first part on the left is showing you just exactly which proportion consumes the most benefits. And as you can see there, from the ages of 45 to 65 plus, they consume the largest part of the healthcare expenditure. And then the other parts are quite smaller in comparison to the amount of beneficiaries in those age bands. Second part is where we've taken per age band expenditure and just superimposed it on beneficiaries to kind of show you where beneficiaries lie in terms of their numbers. So these lines that you see are the beneficiaries, and these bars at the bottom, these are the expenditures by age band. And as you can see, expenditure has increased for all age bands, but most of all in the older age bands from about 60 and onwards. That's where you see the largest increases per age band. Okay, so when you look at PMB benefits paid, PMBs increased by 9.09% in 2024 to 135.66 billion. And a PMB payout still consumes around 51, almost 52% of total benefits paid out. And when you look at the risk benefits paid out, it's around almost 58%. Now, expenditure reported for PMBs is still predominantly in hospital treatments, and that's over 70, almost 71% of expenditure for PMBs is in hospital treatment. And when you look at a per average beneficiary expenditure, that also increased by 8.4% to 1,242 Rand in 2024. Okay, so here what we did is the same. We've superimposed expenditure on PMBs by age band. So it's just the opposite now. The bars are the beneficiaries, and the lines here represents the expenditure. And as you can see, for almost all age bands, that line has shifted upwards, which is the increases seen per age band for PMB expenditure. Okay, so now when you take a closer look at PMBs, I'm going to highlight for you PMBs in hospital and out of hospital for DTPs, and then the same for CDLs. Okay, now I might think that you can't see because it might just be a bit too small. So I'll just zoom in a little bit so that you can have a look at, for instance, just the highest numbers in expenditure. Just allow me to just adjust this for you. Okay, great. So what you see there is 2023 and 2024, where we look at the average spend per patient in terms of that DTP benefits, which is the disease treatment pays. And these are arranged at the highest expenditure all the way down to the lowest expenditure. Okay, so what makes up the greatest part of the total? So as you can see there, it's going descending on the percentage of total. So the largest percentage of total was paid out to metastatic infections or septicemia. And they also have an average, a very high average per patient of about 129,000, 5.204 million. Sorry, that's per patient, and that's the total cost there in millions. Okay, so like I said, these are all available in our industry reports, so you're welcome to go and have a look or ask us for some more detailed information if that's what you're interested in. Okay, let me just go out here and then to the next one, and this would be out of hospital DTP expenditure, both for 2023 and 2024. And as you can see there, the highest expenditure item there was default emergency, which is not a DTP or a CDL. So this is where you have an emergency, go to the hospital, but you don't get admitted. So that's the expenditure there related to those. Okay, and then we're looking at PMB benefits paid. So these would be all the CDL conditions. And what we're highlighting there is out of hospital expenditure and in hospital expenditure, where we have a per patient per month expenditure for 2023 and 2024, and just highlighting the percentage change over time. And as you can see, the largest percentage expenditure still for hypertension, coronary artery disease, and diabetes mellitus type 2. Right, so as we move forward, we're looking at out-of-pocket payments in 2024, over the period from 2014 to 2024. Now, what we do is when we do present out-of-pocket payments, we split it across member direct payment, as well as the self-funded part, which is the paid from medical savings accounts. There has been some questions regarding putting medical savings account forward as out of pocket, but as we still perceive medical savings account as being self-funded, even though there's a specific part set aside for that, it's still seen as a self-funded part of your medical aid. And that amounted to around 23.1 billion in 2024. And that only had the slight increase of 0.27 that I've indicated earlier. But in terms of direct payments by members, so these would be where the total benefit, the risk benefits paid out by the scheme is less than the amount claimed. So that's how we calculate direct paid directly by the member. These, I must say, we still think that it is underreported, because as you can imagine, sometimes when you run out of benefits on your medical aid, you would still fund your healthcare out of your pocket. So, and not all those claims make it back to the medical scheme. So this is just what was reported to the medical scheme. So the claims that was sent to the medical schemes, and us being able to identify what was not paid or covered by the risk. Okay, and that amounted to 23.2 billion, and that outpaces the medical savings account. But if you look at the annual average increase, which is around 11, almost 12%, and the year-on-year average, which outpaced that, it's about 14.72%. Okay, so that is still of some concern to the council, and we are trying to better delineate what it is that those components are made up of. So we're going to go through some more research just to understand what exactly all those are and what type of benefits it is that are not covered by medical schemes. Right, so when you look at the distribution of out-of-pocket in terms of benefits, the largest percentage is still medicine dispense. Now, the inner circle there is medical savings accounts, and the outer circle is direct payments by member. And as you can see there, in both circles, you'll see that medicine dispense still takes up the highest part, followed by some of the all specialist expenditure that's not covered and makes up part of out-of-hospital payments. Okay, medicine dispensed and specialist takes up around 59% of medical savings accounts and 68% of paid directly from the members' pockets. Okay, so some of our utilization trends. If you look at expenditure by general practitioners, for instance, what we see is that there's been slow growth in the number of visits and the average number of visits. So the number of beneficiaries having at least one visit only increased by 0.3%, and the average visits only increased by 0.34%. But when you look at the amount claimed per average visit, that has increased by over 7.8%, right? When you look at dental practices, that is the same, where the number of beneficiaries at least having one visit has increased by 2.17%. And you see that average visits had a slight decrease of 1.4%. But when you look at the amount claimed, that increased by 4.8%, almost 5%. And this trend continues, where the number of visits increases by a very low percentage, like 1.4% for medical specialists, where you see that the number of visits in hospital increased by 4% and the number of visits out of hospital decreased by 0.2%. The average number of visits increased by 1.86% and the amount claimed increased by almost about 6.68%. For surgical specialists, we see exactly the same, where the number of beneficiaries having at least one visit increased by 0.52%. The average visits only increased by 2.10%, but the amount claimed had seen an increase of 8.21%.
Hi, Karen. Carrie-Ann?
Yes?
You have 5 minutes left.
Oh, okay. Okay, I'm going to try and just quickly go through the next.
Sorry about that. We have a tight schedule.
No, that's fine. Don't stress. Okay, so in terms of hospital admissions, you'll see there that we more and more see that schemes are, well, I said moving beneficiaries towards day clinics, where private hospital admissions have increased by only 1.14% compared to the admissions at day clinics, which has increased by 4.8%. Mental health institution admissions are still very worrying, which is over 9.7% increase in the number of admissions that we see to those medical mental health institutions. And provincial hospitals has seen a decrease in about 6.59%. Okay, I also then just highlight the admissions by level of care. You'll see there that it's really dampened. There's not a lot of change. The admissions per 1,000 beneficiaries have only slight variation from year to year. So for instance, if you look at general high care and ICU admissions listed there. The average length of stay also has seen some changes. General ward increased by 0.12%, high care by 2.33%, and ICU by 3.87%. Okay, and then we just have some indicators from the SDGs that we highlight here in terms of maternal health and cancer. And as I indicated earlier, these are all available. We have a lot of information available in terms of our reports as well as annexures and more data available. So you're welcome to contact us to, we can assist you in even having, more detailed information on any of these that I've highlighted. You're welcome to contact us and we can put that together for you. Okay, I'm just going to jump through the next. I'm highlighting some of the immunization, mental health coverage, and eye care and HIV, TB. Now, these are only related to the SDG indicators. So, for instance, if you look at immunization for polio, for instance, this is oral polio vaccine, where we've now seen a move to the injectables, and that is why you see some of these immunization changes that's negative. So just bear in mind that these are the indicators as per SDG. It doesn't mean that polio is not being vaccinated. It's just that the form of vaccination might have changed. Okay, so in conclusion, while coverage has increased, while coverage has decreased, the number of lives has increased. The number of restricted beneficiaries has increased more than open schemes. The age profile still remains worrying, where we see aging of beneficiaries in the medical schemes industry. And then medical schemes are still paying out higher claims compared to 2023. And higher levels was paid out of about 8.52% in the total benefits paid. And then out of pocket, that remains a worrying trend, which is the increase of 7.02%. Now, just in terms of some of the questions that were sent to me in terms of MedTech, how can MedTech use our report? It can assist you in prioritizing markets. So we put out information such as the provincial information telling you where the beneficiaries are, where the expenditure is taking place. So that's information that we have available to you in order for you to prioritize. We also have information on targeting segments where you can see like beneficiaries in the older age bands are the ones that's actually requiring orthopedic, cardiac and oncology treatments, and those are the ones that you can target your segments in terms of that. In terms of the shifts that I've highlighted, we're not moving away, but where we see higher admissions in day clinics compared to hospitals. So those are some of the insights that you can then go and use, and you're welcome to contact us if you need in terms of that. Then just in terms of winning access, where you could look at, for instance, value-based contracting with provider groups or medical schemes administrators, and then improved affordability. So as you can see, the number of visits are not increasing as much as the cost, and that speaks to affordability. Beneficiaries are not affording healthcare, and that is all the more evident as you look at our report. Okay. Then in terms of just CMS supporting MedTech. Now, I've taken a look at the MedTech Master Plan framework that was published by the Department of Trade and Industry, which I assume all of you have participated in putting together. And when I looked at those 4 pillars that was highlighted in the report, where I see us as the CMS being able to assist is in terms of research, innovation, and data. CMS does not collect a lot of data in terms of devices, but that's because we don't have the coding in terms of the devices that are out there. And we would like to work with you in order to collect that information. We can only get the information that's available by the scheme. So if you can assist us in putting together a data specification, that can go a long way in us at least being able to start collecting information on those types of devices. And I think that's where I would put up my hand and say, CMS is willing to work with you in terms of getting more data so that we could strengthen Pillar 4 of that framework. And I think that's about it. Thank you, Christine. You can let me know if there's any questions.
Okay. So thank you, Carrie Ann, very much. Sorry to rush you towards the end. We just wanted to leave the floor at least for some questions.
Okay.
And we do have already 2 in the chat. So maybe I'll just read that out to you. Who should members contact on CMS to get more information? Can you post the email address in the chat, please? And that's from Tanya.
Okay, cool. I'll put my email address in there. I lead the data collection of medical scheme information. So I'll just throw my name in there and put my name in the chat.
Okay, perfect.
Okay.
And then the second question comes from Lebo. What evidence and evaluation criteria does the CMS require for a surgical approach, such as robotic assisted surgery, to be considered for inclusion under PMB?
Okay, so we do have a process underway currently where we're looking at reviewing PMBs by section. So we have panels that work on that. We have multidisciplinary panels, so that would include providers, the regulator, and then associations. So they have set criteria for how they do that. I can also just put you into contact with Dr. Sam Ialo at our office she is the person driving that, and you can have a conversation with them as well as in terms of the criteria and how those things are then included in PMB level of care. So yeah, I'll do that as well, and then you're welcome to just pop an email to her, and she can assist you with the criteria for how that is done.
Okay, perfect. So I just want to say, understanding what the data means or what it means behind the scheme performance and utilization patterns is essential for us to understand or anticipate what the funding behavior would be rather than just react when it happens. So I'm opening up, and it was very insightful as well, your presentation as to what was the key or high points that were identified in your presentation. I'm going to open up the floor to any of the attendees that want to have any questions that they would like to ask you directly.
Okay.
If not, I have one while we wait. So on slide 13, you mentioned there were different types of funding models, such as per diem, fixed fees, global fees. All of those were captured, but there was also one called other alternative reimbursement models. Are you able to, define it a little bit more, or break it down to us as to what that specifically would entail?
Okay, currently we don't have a view of that. It's for the schemes that have reimbursement methods other than what has been listed there. So we have asked for schemes to give us more information as to that. They just usually what they do is they say that it's where they have partnerships, for instance, in their networks and so on. So that is where they put that expenditure. So where they have network models, that's where they have specific network providers that they engage with, that is where they would put that.
Great. So just a follow-up question on that then. Would that be, would that be like your pilot programs that are run for the specific schemes, your kind of value proposition projects, and your preferred supply agreements? Would those all fall under that category?
Yes, that would fall under that category. We also have schemes, such as Lonmin used to be, where they do provide clinics and that. So they have those types of arrangements within the scheme itself. So that's where they would then put some of that expenditure.
Okay, great. Is there any questions from any of the attendees that you would like to ask on the chat or on the call? Okay. I have one more question and then I will leave you.
That's fine.
So, we're all aware that the announcement came out of on the news that Bonitas is leaving MedScheme and moving on to Momentum.
Yeah.
So, as MedTech, how would we plan for potential risks or opportunities in that space? Is it going to impact us in any way or influence the MedTech industry? Because we know the role that MedScheme played within the space of, market share within the private payer. So what's your insights, I would say?
Okay, so this is very tricky for me because it's not my forte. It's not where I spend much of my time. But what I would say is, yes, it will have an impact, especially if you, for instance, see how administrators organize these schemes, right? So it depends on the administrator how they would onboard that scheme. So for those that are dealing with Momentum, obviously there will be winners in terms of now getting this huge scheme, which is Bonitas, and that would be, I suppose, good for those that are in partnership with Momentum and the provider groups that Momentum usually deals with. And then obviously the losers, obviously medical schemes or provider groups and medtech that engage with more med schemes. So it will have an impact. What that impact is, we're not all clear about. And as this unfolds, we're obviously going to take a look and see approach. Yeah, so it is current and recent. So 2026 data will only be available by the end of 2027. So there is this in understanding what changes do happen in the industry. If you think about it, in April now, we will only be collecting 2025 data.
Yeah.
So there is this lag in understanding exactly what impact these changes will have. But what I can say is, if you are concerned, perhaps engage with those associations and provider groupings that you engage with that are part of your partnerships, and just try and leave communication open to understand the changes and how that might impact you.
Perfect, thank you. And I'm sure from a CMS point of view, you will keep SAMED up to date as well if there's any radical changes happening during that period.
Yes, we do pride ourselves on communicating, so we will be sharing information as it becomes available.
Okay. So thank you, Carrie Ann. There is no other questions, and I'm sure once you share your details, there will be people that will reach out to you. So thank you very much for joining and providing the insights into what's happening within the industry. Have a good day.
Thank you so much.
So our next speaker is going to be talking to us about demystifying the Life Healthcare's procurement process. His name is Passmore Musangwa. Passmore is a health procurement and category manager with over 10 years of experience across hospital and clinical supply environments. He specializes in strategic sourcing, cost optimization, data-driven decision-making, bridging clinical realities and commercial strategies to deliver sustainable value. Today's session is particularly important for suppliers engaging with the private hospital environment, and Passmore will provide us with insights into transparency into how procurement decisions are made within a major hospital private group, practical guidance on supplier expectations and evaluation criteria, and insights into how suppliers can engage more strategically and competitively. So Passmore, thank you very much for your willingness to be on the call today and to provide us with this transparency and information. So it's over to you. You can share your slides.
Good morning, everyone. I'm just going to share my slides quickly, but for those who don't know me or haven't seen me, this is my face. It will not be on for the rest of the presentation, just so that I can save bandwidth. But good morning and thank you for taking time to listen to me go through the presentation. So just give me a second to put up my slide deck and then we can get started. Please let me know when you can see so that I can start.
We can see it. Thank you.
All right. So thank you and good morning, everyone. I will try to stick within the time limits that I have today. I think for several of you, we may have engaged at some point as part of the Life Healthcare procurement team. So some of this won't be news to you. So there isn't a lot of mystery to our process. But for those who are not familiar, I hope this presentation will sort of give you insights into how we operate, who we are, why we do the things we do, how we do the things we do, and then it will empower you to engage with us in a more strategic manner if that comes about. So the natural point to start with is who we are and what we stand for, right? So sorry. So let's start with our philosophy as the procurement department. So a high level, it is to deliver high quality, cost effective care. This speaks to the mission statement of our group, Life Healthcare Group. And this is primarily driven by legal compliance, quality, sustainability, and socioeconomic transformation. This is what we stand for, and these are the guiding principles that, so our north, our compass pointing to our true north, and this is what we use as the basis of any engagement, any decision making, and it aligns with the company's mission statement. So what we've been doing as the procurement department, we have embarked over the past 5 to 6 years on just stepping up to the next level. And this was through supply chain transformation, risk mitigation, and then transformation of the internal procurement team. So this is people, processes, data, and systems. And I'll explain a bit more about that in the slides to come. But supply chain transformation really spoke to ensuring we have partnerships, strong partnerships with our suppliers, strong partnerships with other stakeholders like the funders, the doctors, and of course the most important stakeholder, stakeholder was the patients. And we were doing this by ensuring that these are the right partners for the right objectives that we're trying to achieve. This would have entailed risk mitigation, so there's a lot of inventory management, a lot of capital expenditure, price management, and compliance management, which we have worked throughout the year for continuous improvement to ensure that these come up to the standards that we need them to be and are aligned with the strategic goals of our company. And we are also working with other departments within our organization to ensure that we have more robust third-party risk management, complaint management, and sustainability, a sustainability drive. This worked hand in hand with just transforming the internal department of the procurement team with different roles and responsibilities, making sure our processes, procedures, policies are up to date, are current, and are relevant for the current environment and our strategic outlook as a company, ensuring that we get more data so that we can make better decisions based off of the data that we have, and systems to enable all of this to run smoothly and remove the administrative burden so that we can actually focus on seeing the wood from the trees. So the people piece, after a lot of restructuring and rethinking of what the department would look like, this is the overall structure of what the procurement department looks like. We report into our CFO of the group, and the head of procurement is Ilham Solomons. We have an administrator who reports into Ilham and usually would be a point of correspondence with many of you on this call. You may have received an email or two from Tsulufelo. And then under that, we have Mohammed, who heads up the product database team and is in charge of projects, Mohammed Suji. There's myself and Hendrik, who are the category managers, and we take care of the sourcing team. We have the contracts manager, currently vacant. We had one who left, but the recruitment is almost complete. So we should have someone in that position very soon. And then there is a newly created designate position because Mohammed, I'm sure a lot of you know Mohammed. Mohammed has been there for a long time. So it's getting to that time where he wants to go and relax on a beach somewhere. So we need someone to absorb all of the IP that he has gained over the past 40 years or so working with the company. And then there's, for Mohammed's team, there's the support team with product database who manage our price file and other supplier queries. There's an administrator who helps also with the contracts management. And then the procurement system specialist for any procurement systems that are customer support related, and also managing some of the queries in terms of price variances. And then Hendrik and myself have the supplier managers reporting into us, where most of the sourcing activities are done, and then they manage the contracts and commodities based on what we've contracted with the partners that we have. Right. So that's who we are. That's the people piece. That's the transformation. And then the next piece was the data and systems. So we have been working on many systems. First, we wanted to make sure that our internal customers are their needs are met. So there's a procurement category management system, which is in the late stages of development. This has been 18 months or so development, quite a robust system that will give us more insights and help us to understand where we should be finding efficiencies and how we should be engaging with the likes of the Meta community from the data that we get there. There's a vendor onboarding system that is currently internal facing, where the business units, if they need a vendor onboarded, they can do that. And then it goes through all the governance processes and gets reviewed by the relevant departments or functions within our organization to make sure that all the legal and compliance and quality measures are reviewed, security as well, in terms of cybersecurity and other things before we onboard the vendor. Then we have a contract management system, which went live sometime last year. Unfortunately, for many years, our contracts were being managed on Excel. But luckily, we have a system now that has all our information and helps us to have a better view of what's going on with the contracts that we have in place. And then there's some customer engagement modules, but internally facing. So with our internal customers, either other business units or business functions within our organization and the hospitals as well, so that they can engage with procurement. And one that will affect everyone on this call is a tender system, which is very, very imminent. We are in the final stages of configuration and testing, and we should be going live in the next couple of weeks. So we will send out a communication to many of you around this new system, which we hope will improve the bidding process. And in orange there's ERP migration, which is fortunately or unfortunately something that the organization has to embark on. So we are busy scoping that out, mapping it out, and seeing what direction we'll go. And this is obviously a huge project and takes some time. So it's in the early phases right now, but it's always important for our for many stakeholders that we deal with to understand what's coming up. So you saw that there were category managers as part of the sourcing team. This is a new role that we added a couple of years ago. This was not the structure previously within the department. And there are many, many reasons for it. And this also paints a picture of how we do our procurement, how we source. And I'll dive into what that means. What is category management? Who are the category managers? What does it mean for you? What are we looking for? And why are we doing this? Right. So we had a very transactional relationship in the past, which was right for that time, right? In the past, it was a very transactional or tactical relationship with many suppliers. And it works to a certain extent. You can only achieve so much from what we've seen with tactical relationships. We want to go to continue maturing as our business matures and our department matures. We want the relationships with our stakeholders, the suppliers, to mature as well. So we going from a product-based, tactical procurement strategy to more of a category strategy, which involves creating stronger partnerships and leveraging on those partnerships, sharing risks, and then bringing more value both to ourselves and to the partners that we engage with. So you can see on this slide here that you could say we were in stage 1 and we've been slowly moving through the stages, and we're around stage 3 now, and this is where we think we'll get the most benefit with our current situation, and this aligns with the strategic goals of our company. So, like I was saying, we used to have a very commodity-based procurement strategy, but then now we're doing more of a category-led planning, which we'll get into in the slides that come next, and I'll explain what that means. So what this would entail is deeper supplier integration, standardization, and value delivery. So this means it's not us and them, us being us, the business, and them being the suppliers, the people on the call. We need to be one unit, and that is how we can deliver maximum value for all stakeholders involved. So there's a lot of integration, and we almost bring our businesses together to be one so that we can bring out the best value. This allows us to ensure supply chain resilience, quality standards are met, kept, and we can improve on those. And all the governance requirements are also kept in check. And then ultimately, this helps us to deliver our company's strategic goals. And in the process, because we are sharing strategies between the suppliers and our company, we should have shared goals, and by delivering on our strategic goals, it will deliver on your strategic goals. So why are we doing this? And what is it? Like I said, it's very structured, strategic approach of procurement of everything from services to goods and capital. So instead of breaking the reviews and the contracting into small baskets of very specific goods and spend on that goods, we're looking at things holistically at a category level to see what goods, services, capital is linked to this category, and how can we leverage the knowledge base of our partners, our knowledge base, and then come up with solutions, category solutions that are mutually beneficial and have a holistic approach in terms of answering the problem statements that are put forward. The reason for this is this volatility I think we've seen the past few years that a lot of events happen in the world that just change the landscape, and we have to pivot. And if you don't have deep integration and strong partnerships, it is very difficult for you to survive those situations. This global pressures also feed into some local pressures and so the macroeconomic environment and local economic environment also puts pressure on us to find efficiencies and to work in a different way. So this is why we have gone into this strategic, structured category sourcing and made sure that every category is still whatever approach we take in that category is still aligned to the overall goals of our organization. So the focus areas would be, market intelligence, risk analysis, usage analysis, everything that's listed on here. And throughout the conversation or the presentation, it should be apparent where each aspect fits in, right? Further to that, there's been some operational changes within Life Healthcare. So strategically, Life Healthcare is expanding quite a lot, the business areas. We're expanding a lot in the complementary services area. And they are for the acute facilities, the hospitals, there's rationalization. Some will be repurposed or we'll see if they're serving the correct needs for the communities around them. Very few greenfields projects, where there's one in Paarl and another one that we should be announcing very soon. A lot of brownfields, which is part of the optimization of our assets and making sure that our assets are being used efficiently and aligning the hospitals in the different geographies to make sure that we are either not over, we don't have undersupply of patients, or they aren't regions that are not adequately covered. But that's a small piece. The larger piece is the expansion in complementary services, renal radiology, or let's call it diagnostics. And this is part of Life Healthcare's goal of not just being a hospital group, but a healthcare company. So we're taking a cradle to grave approach where we are going to capture a life from birth until death, as morbid as that may sound. But we are trying to have a service offering throughout the journey of someone's life. And this is part of why we are expanding aggressively in the complementary services. So this also necessitated a change in the sourcing approaches, right? We've had CMS presentation just before me, so this might be a repeat of some of the insights that have been given, but this is also a driver for us. As many of you are aware, the number of funded lives have not been growing for quite some time now. It's remained stagnant, even though, and it's being outpaced by the population growth. The population is aging as well. There's a lot of buy downs by the members of the schemes. And the costs of healthcare continue to increase. This then necessitates us to find ways of being more efficient through different types of partnering and looking at some of the sourcing strategies quite holistically. This data is from 2000 to 2022, and you can see from around 2010 or so, it has overall remained flat, even if you look at 2023, 24, And with the information that has been shared by the previous presenter, we're still around 9 million, just over 9 million beneficiaries in the country, which is about 14% of the population or somewhere there. And that puts a lot of pressure on the private healthcare system. And because there's an aging population and more pressure on funders and the reimbursement, there's also a lot of drive from the funders for the hospital groups to be more efficient, which forms the basis of how we've been starting to contract with alternative reimbursement models, network deals, global fees, and we are moving more and more into that space. And this means that we have to look at things and how we partner very differently.
Very possible.
So,
Just a
yes.
time watch. You have 10 minutes
Okay.
presentation. Thank you.
All right. So I'll skip over the benefits because these are kind of inherent in what I have been speaking about. And the category management is not something that is new, that we invented. This has been implemented by many, many companies, large companies around the world, and they've seen a lot of benefit both from their standpoint and with their supplier base. Right. So what does this mean? What is an example of category management? Like we said, it's having a holistic view of services, goods, and capital, all forming part of a category, a basket, and then looking at it holistically how we can partner with suppliers at that level instead of at a commodity or item level. So an example of this is patient ventilation, which we've looked at as a category. And the purpose of this is just to give you an idea of how you should be thinking should you engage with Life Healthcare at a category level or at any sourcing event, right? So we had a phase one of a ventilation where we looked at the procedures. Do we have the procedures and processes in place? Is the staff well educated on what they need to do? What are the consumables that are used? These are the types of consumables. And just making sure we have contracts for those. So this was phase one when we were looking at it more tactically at a commodity level. And then we're looking at the capital. Are the consumables compatible with the capital that we have? But then phase two, looking at more holistically, okay, we've finished the goods part, the medicines, we've got contracts for some of the consumables, the processes are there. How do we look at it now more holistically? What is the capital that we need to replace, and how are we going to do it? How does it fit into the goods and the services that are linked to this? What is the IT support, the future roadmap for our IT strategy? How does that fit in? And this formed of the review. And what we do is then we ask the bidders or the partners to come up with proposals of how they would partner with us on a holistic view from goods, capital to the services. And another element of it is sustainability. What can you also come up with, or how can we partner with you on environmental sustainability level, and what aspects can you bring? And this is what we take into consideration. So it is the holistic view. And you'll see I'm just speaking about a lot about governance, compliance, quality, sustainability, and all of these things. This is part of what we consider. That's why the proposals have to be robust. And then within Life Healthcare, every review, it's not a procurement department decision. This is signed off by every business unit that is involved in use of these goods or services. So you will have, for the ventilator one, we had nursing, we had infection prevention, we had the clinical engineers, we had infrastructure, we had our sustainability team, we had the operations teams, finance teams. So we look at it holistically. It is and then of course, we have the clinicians. The clinicians are consulted. There is a clinical directorate team, which is a team of doctors that also give their input, look at research, what is going on in our hospitals, what are the protocols, what should be done, fit that into the information that we get from the suppliers on global trends and insights into where the industry is going. And then that forms the decision. Obviously, all of this then leads into the total cost of ownership. So what is this holistically going to cost us? What does it look like for the next 10 years? And then this is important in how you engage with us so that we can ensure that we have a holistic view and the correct decisions are made, along with all the non-negotiables, which is governance, compliance, and obviously we are very, very focused on transformation as well, socioeconomic transformation, so the BEE scores and local manufacturing. All of these things are taken into consideration. We go through governance reviews and conformance reviews when we get the proposals. We then go through technical appropriateness, technical reviews with all the business functions and the subject matter experts. This may entail some demos, some evaluations of the products or goods or services, and then we go into the commercials and then see if holistically does this make sense, and then it goes through the sign-off processes depending on the value of and size of the category and the spend. It goes through the different approval processes all the way up to board level. So it is a very involved process that there's a lot of consideration and a lot of consultation and debate amongst many stakeholders. So we try to make it as robust as possible, and then it also feeds into our strategy, our funder strategy, and how we then contract with the funders. So what this means from a vendor perspective is there's going to be segmentation. Obviously, this is what happens. There will be vendors will be strategic, some will be core, some where it's tactical, and then there's the watch list where these will be vendors that are not performing according to the set of standards that we have, and we would therefore not be able to go on the strategic or partnership journey with them. So they will be under review either for performance improvement, or we need to be honest if we need to continue with that partnership. But I'm sure everyone wants to be in the orange block, and that's where we're striving to get everyone to. So your performance earns you the right for the partnership. So we need to get the basics right. And we have been on this drive with most of our suppliers. Let's get the basics right so that we can go into those strategic partnerships. So quality and delivery needs to be, these are the basics: quality and delivery, compliance to the contract KPIs. We need smarter cost controls, come up with plans of seeing how we can get a better costing, or be more cost efficient, reduce wastage, correct utilization, things like that, ESG alignment, and innovative input. And this is what we expect from our partners. But this all of this has to be, the foundation is getting the basics right. So this is similar theme. I won't go through this because it's pretty much what I've said in the previous slide. But I just wanted to emphasize that there is interlinked success here. When we go into these stronger partnerships or integration of our businesses with our suppliers. Our performance is interlinked. So the performance of us as the procurement department, the performance of you as the vendor that we've partnered with, and the performance of Life Healthcare is interlinked. So we are trying to get to a point where we all gain, we win together, and when we lose, we'll lose together. But there's obviously a lot of risk that is involved with that. This is why we are trying to have a more robust risk mitigation put in place. And then that's why you'll see us asking for many, many things and having quite stringent standards that you have to adhere to. This is because there's a lot of operational impact if things go wrong. Our strategy is to get the basics right with our partners so that we can have a situation where we're interdependent. But if we're interdependent, if anything goes wrong, there is so many downstream effects that will hurt operations, which would lead to loss of revenue or frustrations in the system and loss of reputational damage, both for us as an organization and as a department, but for you as well as a supplier that we've partnered with. So it's always good to get that right. Yes.
Excuse me. Our next speaker is online.
Yes.
Can we be able to just wrap up, please?
Sure.
Sure.
Okay. So that's that. So yeah, I think I will just touch on contract management a little bit, although, okay, maybe for the purpose of this presentation, we'll stick to this because contract management is more of when we've already decided to go with you as a supplier. So then we'll get to that contract management discussion. What I will do is I'll skip towards the end of this presentation because there was a question that had been sent to me about how new products or entering into our system, how we can do that. So we have formalized process where there's new applications and then these are sent and then reviewed by a multidisciplinary team, and then you get approvals to market these into the hospitals. If the hospitals want to use your products, they will then request that these be loaded onto our ERP system. If you haven't been onboarded, then you would be start the onboarding process there. And where it is not permitted because it's in contravention of current contracts, we will communicate that and then tell you when an opportunity would come up where we would go to market so that we can have a different view of what's going on and a different supplier base, right? We also have an internal HTA, which is again multidisciplinary, and then for medical equipment and medical devices as well as medicines. This is quite new for our company, so it's still finding its feet, but we have been reviewing quite a few things, and then decisions are made by this multidisciplinary team. And you'll get the communication on what you can do and what we are going to do as a company after we've reviewed everything. I don't need to take you through the process flow because we've run out of time, but it is quite an involved process. We are thinking of breaking the HTA, the medicines portion, to a therapeutics committee or a subcommittee that would then review the medicines portfolio, which doesn't affect the people on this call, but that's just good for you to know. And this is part of how you can have introduction into the business apart from our standard tender process or review process, right? Okay, so I will stop there. I hope that it was somewhat insightful. I'm sorry that we had to speed through some of the aspects, but if there are any questions, I'm happy to take them now.
Thank you, Passmore. It was very insightful. Now we know that, procurement is no longer just a transactional, decision. It's becoming more strategic and data-driven and outcome-focused. So we're happy to hear that Life Healthcare is, moving towards that kind of pathway, where you're looking at engaging and partnering with, different stakeholders to ensure that patients get access and, for the right treatment. We do have a few questions on the chat, but I have Tanya who has a hand up. So maybe Tanya, you can go through.
Thank you so much, Passmore. It's Tanya. I'm the Executive Officer of SAMED. Just some comments around the HTA. It is becoming quite a challenge and duplication of effort and resources, and all of that costs money for medtech companies to have to do multiple HTAs. They're already having to do them for the medical schemes, for other hospital groups. And so I think what I'm asking is, please do consider this, and also to please consider the ISPOR One HTA initiative. Because if we can have similarities in terms of the processes and the requirements and the documentation, it would go a long way to preventing that unnecessary duplication, which becomes, at the end of the day, a hurdle potentially for access into the market, and also a costly exercise, especially for suppliers, well, across the board. The majority of medtech suppliers in South Africa, the majority of SAMED's members are small to medium companies. So every additional request and hurdle takes time and effort. So HTA has, ISPOR has this One HTA initiative, and I would really request that be considered. And then just in terms of your categorization project, but even when it comes to your HTA processes, please can you consider engaging SAMED on that? We have a market access committee that is looking at these matters, and we would love to be able to give some inputs to those processes. Ultimately, they will affect the medtech sector, and we will make sure that our views are independent of any bias towards any one particular company, but are on a principle basis. So just to request that of you.
No, thank you for that. Both points are noted, and we do understand that there is somewhat some duplication, although our HTA is not as involved, and we also take into consideration other HTAs that would have been done. But we've also found that HTAs that are done by other parties may come up with a result that is not aligned with what we want to do as a group. So if, for example, if the HTA says there's no benefit in robotic surgery, but we see that with the way we want to go, we want to review this. This is why we needed to have something just to understand if what is in front of us and where the market is going aligns with what our goals as a company. But it is noted that we need to leverage on other HTAs that are happening. Yeah.
Thank you, Passmore. Thanks, Tanya. So we just have 2 questions in the chat, and it's from Norma Gugu. The first one, Passmore, is: will performance measurements managed by procurement alone or jointly with the clinical teams?
So the performance measurements are joint with it depends which stakeholders are affected. So there will be clinical engineers. So let's say it's medical equipment, the clinical engineers, the nursing staff, the pharmacy staff. So operations would be monitoring as well as procurement. But as procurement, usually for central agreements would be the owner of the contract. We would then execute on the performance measures that they've put forward, or performance issues that they would have put forward. So where there's good performance, you will be notified that you're performing well, and where there's poor performance, you will be notified that the performance is poor. But it is not just procurement, it is throughout the organization.
Thank you for clarifying. And the second question is, beyond price and delivery, how do you incorporate clinical impact and program support into the management processes you are driving?
Yeah, so like I was saying, price and delivery would actually come last. So clinical impact is what we review first. That's why we have all of these teams, multidisciplinary teams, and the funded teams, and involve everyone to understand what the clinical impact is. Can we improve patient outcomes? With the way we are contracting with the funders and with our ARMs, and some of the global fee contracts that we're going, which is part of the VBC value-based care, clinical outcomes is one of our measures. We actually, our tariff increases are dependent on better clinical outcomes. They're dependent on obviously cost per event, patient satisfaction scores. So all of these are part of the holistic view of what we look at, and it's incorporated into the entire sourcing process, because we need to understand how that's going to affect the patient experience, clinical outcomes, and obviously the cost of doing any procedures before we can make a decision, because this is what we will then take to the funders to say, this is what we are capable of doing, this is what we should expect, and then this is how we then contract on a value-based care model. So it is very important, and it is what we consider primarily. Then we see how we can make it cost efficient after we've made sure that it ticks all the other boxes.
Thank you so much. Would you be able to share your contact details or the contacts of whichever procurement team or category managers that the attendees would like to reach out to following this presentation?
Sure. I'll share in the chat after I have after I'm done talking. So there'll be one email address, which for those who are not registered with Life Healthcare, there is a portal, a form where you can complete your details, leave your details, so that we can invite you to tenders, and then you can participate in those tenders. And then for those who are familiar with us already, or registered with us, I'll give myself and Hendrix details as the category managers.
Perfect. Thank you again, Passmore. This was very insightful, and hopefully it was helpful as well to the attendees that are here. I'm sure you'll get a lot of emails following this meeting or presentation.
Yes, I am sure that will happen too. All right.
Thanks for joining.
Yes. Okay.
So
Thank
now
you, everyone.
move on to our next speaker. Thank you. Our next speaker is from MedScheme Health Policy Unit, who will be talking to us about MedTech HTA update. Her name is Christine Keita. Christine brings 29 years of managed healthcare experience, including 25 years dedicated to health technology assessments and clinical protocol development. She leads the technology division within MedScheme's Health Policy Unit, overseeing HTAs and funding protocol development for medical devices, technologies, and clinical procedures. Her insights are critical for everyone seeking reimbursement within medical schemes administrators' environments. Today, Christine will provide an insight into the recent HTA developments and policy priorities, clarity on evidence requirements for medtech and reimbursement, and context for stronger engagement with medical schemes. Thank you, Christine, for joining. And we appreciate you and apologize actually for running a bit late, but we appreciate your time. So it's over to you.
Thanks. All right, can you see my slide set?
Yes, we can. And we can see your beautiful face.
Okay, right. All right, morning everyone, and thanks for having me. Yeah, so I'll try to answer all the questions in my slideshow. Sorry. No, the slideshow doesn't want to run. No. Okay. All right, so the points that we will discuss today is the MedScheme reimbursement process, or the application process, and then also our health technology assessment and funding protocol process. And then we will just briefly look at the governance and operational forums that we have, and also just a few words on scheme engagements, and then also look at information that is required from industry for the application of reimbursement. Yeah, so I mean, it's sort of logic, but just to say again that a supplier must have an API code for the MedScheme systems to be able to reimburse the products electronically. And we've got a department. It's our MedScheme Clinical Coding and Tariff Department. We call them CCTD, and all the new NAPI codes that comes in every day from Medicare via this South African public domain NAPI file is added to the systems, to our systems by this team. If we talk about Me Too products, which comes up a lot, I just want to define what we see as Me Too products. This is where the clinical outcomes and the price is the same or lower than an already reimbursed comparator, and therefore it will be usually automatically approved when these type of codes comes in. Having said that, the clinical outcomes for devices required will differ according to the type of device. It will be wildly different for if you just bring in another catheter versus a valve or a prosthesis that has to stay in a patient's body for many more years. Okay, so these Me Too products, or any product that fall within an existing device category but is priced higher than the comparable device that's currently on the price list, will decline for reimbursement, and the supplier will be notified. And further information can then be provided, clinical and economical, on this product to justify the higher cost or price. And where the information supplied is not considered sufficient, the supplier will need to follow our health technology assessment process, which we call the HTA process. And for any new technologies, the HTA process or new concepts, the HTA process is always needed. Also for HTAs, when we have an HTA for a product, for instance, with one indication, but there's now a new indication with new evidence, then that process will have to be followed again. Okay, so our contact points is if you just want to find out if your NAPI code will be funded or not, if it's open for funding or closed for funding, then that inquiries go to our clinical coding team, which is the address, the CCTD at MedScheme, which many of you know. If you want to submit a new HTAs, then this can be sent to the health policy unit, the tech team. This is my team. We've got an inbox for those, and this is the inbox there. So this changed slightly because in the past we said everything must go to the clinical and coding team, but we've changed that because they just become sort of a post box. So we said new HTA submissions can come directly to our unit and to our tick box. If you want to follow up on progress of your HTA, so if you are already busy with it, or you send it in like a few months ago, in those inquiries also goes to this HPU tick box or inbox, or you can send it directly to one of the HPU team if you are already in contact. So sometimes one of my team will start with the HTA. They will ask you a few questions or ask for more evidence or information, and then you will know, but this person is busy with my application. So then if you have questions, you can send it directly to that person. Our process, our health technology assessment process, takes about 3 to 6 months. We really try to stay in that timeline. Here and there, we do go out, but not much, usually a month or so. Yeah, and then we usually do not do intermittent contact with the company that has applied unless we need additional information. So it's not that we're going to say, we start your assessment now. After a month, we're still busy with your assessment. We don't do that. You're welcome, if you want to know where we are with it, to contact us also again via the HPU inbox. Then what information do we need or is it required in the application? So we will usually want to know what the registrations are. So is your device in your company SAHPRA registered? Is the technology internationally? Is it FDA, or does it have CE approval? And then also, of course, the NAPI codes and the pricing. Then evidence-wise, we would like to know, is it already included in local international guidelines? We want to know, or you have to send us the systematic reviews, the meta-analysis, the randomized control trials, any studies that you think will be of value. Also registries, we also look at that. And then also let us know, is there training required? Is there a learning curve? Do you plan to have centers of excellence? And then we also would like to know the CPT codes or CCSA codes, as it's been called in South Africa, and which national reference price list codes the doctors will charge if applicable with this technology that you have brought on the market. And then we also would like to know if it is state access, if it's on tender, if it's on buyout, and because I hear a sound like dropping out of the meeting. Can you hear me? Can you just indicate if you can hear me?
Oh, we can hear you now.
We can hear you now. Okay. Did I drop out?
You froze a bit on my side. Not sure about the rest.
Okay. All right. Okay, I'll just reply the last sentence or so. So the last bullet that we have here is the codes. So CPT or CCSA codes or national reference price list codes, deductible charts when this technology is used. Then state access, is it on tender, on buyout? What is the clinical indications, criteria, and cost? The comparators for this technology that you bring on the market that's currently available, cost comparatives with the alternatives on the market, either conservative treatment or surgical treatment, and then the equipment fee is the equipment fees that will be charged by the hospitals. This is now where applicable, and then if this is not a must, but if you have health economic modeling with the assumptions, then you can also provide us with that. So our process, health technology assessment process. So The role of health technology assessment is to provide an evidence-based framework to guide responsible, sustainable healthcare decisions by assessing both the clinical effectiveness and the economic value of health technologies. And our HTAs inform also the development of our funding protocols that's been used by our operations. So then the role of funding protocols, it is to translate the HTAs in clear, consistent funding rules and to ensure that we have responsible and defensible, we make responsible and defensible decisions. It's also a requirement from the Council of Medical Schemes and Medical Act 15.3 say that managed care organizations must have protocols, and it also says that protocols must be developed on the basis of evidence medicine, taking into account considerations of cost effectiveness and affordability. This is now in the Medical Schemes Act. And then also to support compliance and quality and sustainability. Now, what do we take into consideration when we do our assessment? So we will always look at the clinical appropriateness. So is this technology safe? Is it effective? Is there long-term outcomes already published? Is there a learning curve, especially in procedures? It's quite important because a learning curve can cause additional complications and longer theatre times. And then we'll also see if it enhance or replace best practice, and if the outcomes is comparable or better than current best practice. We will also see, mostly for new technology, it's not PMB level of care, but it may be PMB level of care. And then we will look at the cost of the disposables. We will see if there's equipment fee. We will see if it increase or decrease theatre time, if it decrease length of stay, level of care, or maybe complications. And then also if it can maybe let a procedure be done out of hospital versus in hospital, which should be a saving on your theatre fees. And then also we look at the cost versus time. Have to take into consideration our scheme rules, because every scheme has different procedures benefits. They've got different exclusions, and some of them have co-payments, and sometimes it differs even between options on schemes. And then also some of our schemes have provided mandates for here and there. So yeah, we also take that into account. And then in our research process, we use different resources or references. So we will look at medical journals like the New England Journal or the British Medical. We also will use electronic clinical databases such as Cochrane Library and UpToDate. And we will also see if there are international and sometimes even local clinical guidelines. And also we will gain many times expert opinion where needed. And then we will also look at what other international payers do. For instance, Aetna and Cigna is US-based and NICE is UK-based. Yeah, so we also see what their criteria is or their funding decisions. And then we will, of course, always have to look at the cost of the new tech versus what is currently available. Is it does it replace cost? Does it add to cost, etc.? Yeah, so there's all the things that we will take into consideration before we do a funding decision or funding recommendation. And yeah, many of you may know this, but I just thought maybe I can just show you again the hierarchy of evidence. So your best evidence is always your systematic reviews that include randomized controlled trials. And then it goes down to randomized controlled trials, and then meta-analysis who doesn't have randomized controlled trials, and your cohort studies to case control. And you can even see your mechanical studies, to mechanical studies. And then at the bottom is your expert opinion. So yeah, many times we get expert opinion, but it is expert opinion, and it's very low on the scale for evidence. So yeah, so the higher your studies is on this pyramid, the lower is the risk for bias, and the better is quality of your evidence usually. And there's a lot to say about, especially in the technology world. It's not always possible to get your best randomized controlled trials on every device, and we know that the devices change and there's new generations. So yeah, so that's why I think in the technology world we are more lenient than, for instance, in the drug world with regards to the level of evidence that we will take into consideration for a funding decision. And then, so now if we've got all our clinical evidence information, and we look at this cost sustainability, then we make a funding recommendation, and that will be either we're going to approve this, we're going to decline it, or we will fund it if it meets specific clinical criteria. I just thought maybe to briefly refer to our funding options. So we've got different options, and you get your fee for service, and this is where every NAPI is individually quoted and funded, and there's, for instance, might be an endoscope fee, and there's a fee for your ICU and a fee for your general ward, etc. And then there's also equipment fee. And maybe also to say that the NAPI codes may link to different benefits. So it may link to your prosthesis, or it may sometimes even link to auxiliary, or it will link to your overall benefit. And then we've got fixed fees and global fees, which will also global fee usually includes everything. Fixed fee has different sections, but it includes more than just your line by line account. And then we have a few alternative models also. For instance, our joint and back program, where your prosthesis will be included in the fee. And we've got designated service providers, for instance, like our the renal dialysis networks, where there's a fee where there's technologies and devices included. And yeah, for instance, the audiology networks also. So following our assessment, we've got different forums that our protocols and HTAs are discussed, and this is for governance purposes. So just to repeat, the HBU is sort of the first governance, because we see that there's structured methodology in that these evidence-based recommendations, funding recommendations. We do factor in the strategic priorities and the scheme rules and the benefit designs. But then we've got external panels for some of our specialties, such as oncology and cardiovascular and psych and orthopedic. And they provide the unbiased expert validation, and the schemes also use them for oversight and for approval of our protocols. Then we've got a clinical governance and quality forum, and they see that they basically have to accept our recommendations, funding recommendations, and they also provide a broader internal strategic oversight, see that the clinical governance principles was applied, that it's relevant for the MedScheme strategy, and that it's financially sustainable, and that it's also operationally feasible. And then it goes to our Care Excellence Forum, which is a more operational type of forum. So this triggers then our operational teams to implement the funding protocol, and they take all the different operational considerations into account. And then the system changes will also be made based on this forum. So if coding has to be open, close, whatever rules has to apply, that will be done following this meeting. And then also if there's training required for our agents or any clarity, that will come from that. So as you can see, it's quite a extensive process that every HTA goes through, and that unfortunately makes it the timeline a bit longer. but it's necessary for us to take it through all these forums and yeah. Okay, so just a few words on scheme engagement. So we provide a monthly and a quarterly report to all our schemes on all the new technology, all the new actually protocols that we have put in place, but also if there was changes to the current funding guidelines. Say if we didn't fund something and we want to start funding it now, that will also go to our schemes. So yeah, and then we have to indicate the possible effect that if we fund it or change funding will have on cost and also on outcomes for the patients. So we do a summary for them on that. With regards to industry interaction, there was this question about maybe more close with the schemes. Is industry are always welcome to approach schemes directly, and some do. Yeah, so most schemes doesn't have a different type of unit like the health policy unit who does research, etc. So they will require our unit, health policy unit, to do a review of the information submitted, and maybe even more extensive. And yeah, so yeah, I mean, if there's maybe more questions on that, then you're welcome. But yeah, this is what basically from our side. And then I thought, yeah, to look at more industry specific information, maybe just give a bit of advice or guidance on when you do application for reimbursement. So it is very important that you provide complete applications to prevent delays. So we do have a MedScheme template, and well, there's sections for all the information that I've just went through that we want from you. So if that is completed, then it makes our work just, or our world just much better, because then we don't have to ask again and we don't have to look ourselves for information. But we use what you've supplied to us, and we also do our own research just to make sure that we didn't miss anything. And then, okay, maybe a bit of advice is to, if you can, to focus on, I call it return on investment, but it's basically the scheme is going to spend now probably more money on something. And then, so the focus should be on, how does this compare to what we standard do? And is there any downstream cost savings? What is the benefit of this extra money that will be spent? I mean, if it's not extra money, then by all means, it's great. And then also, if claims are made to say that, there will be shorter length of stay or shorter theatre time or lower recurrence rates or reoperations rate, then we need the evidence for that. I mean, sometimes it sounds logic to us, theoretically, but we need studies to back up what your claims are. Otherwise, yeah, it's difficult to explain to the schemes why they have to fund something or add something to what currently is used. And then also, I mean, if you have a proposal already on training and accreditation and maybe centers of excellence for difficult and expensive technologies, it's really reassuring to the schemes. Because they feel that there's a bit of oversight to make sure that not everybody use this and maybe cause longer theatre times or complications or inappropriate use or whatever. So that's always great. And then, yeah, as I said, you have to keep in mind the global fees and fixed fees arrangement, but because, I mean, you sometimes bring a device in which is similar to what is already, for instance, in the fixed fee, but it maybe costs more. So the question is, will the hospital use that, include that in that basket or not? Yeah, and also, yeah, I mean, we've recently had more requests for reusable, for instance, scopes. For disposable scopes. So, for instance, we will already have like a fee for a reusable one. And now how is this going to be funded? Is it now an addition if there's a global fee or a fixed fee, and the scope is much more expensive, then the hospital may say, but they're not going to include it or use it. Yeah, so just keep that in mind. That's not for all technologies, but sometimes you have to think, where does your technology fit in the hospital world? And then also, just want to say that hospital negotiation team is responsible for equipment codes and fees. So we many times get requests from industry to, about a code. Many times they will have to do a new equipment code has to be generated for new technologies, and a fee has to be negotiated. And that is not something that the health policy unit do. That has to go through the hospitals. Hospitals will usually, if they're interested in buying a new equipment, and then most of them will already have worked out what the equipment costs them, how many times they will use it, and what the fees that they should charge. And they usually negotiate this equipment fees with our hospital negotiation team or unit.
Christine,
Yeah.
just 5-minute call. I do know that you have another meeting promptly at 12, and we also have some questions in the chat.
All right.
Like
Okay. Okay. So I'm sort of on my last. Okay. So sorry, I'm sort of I've done that. Okay. So some challenges that we have is when technologies is brought into the country that do not have outcomes data to support the safe efficacy, and then also when technologies are introduced to the providers and the hospitals before Medscheme had a chance to make a final decision on funding, and then also we do sometimes find that the devices are linked to the incorrect categories at Medicredit, and then therefore assigned the wrong funding outcomes. So just check that. And then if you've done significant upgrades to already funded devices, which has added cost, it has to be cleared with us. And then the PMB story always is, if something cannot be considered PMB, if the diagnosis is not on the CDL and the technology or the procedure is not routinely done in state. And then another challenge that is always there is that most patients have a prosthesis limit of only 30 to 60,000 Rand. And as I said, some schemes do give mandates. But yeah, that is the issue that we usually have for expensive prosthesis that's brought into the country. Yeah, and there was just a question on innovation. So I just thought my thought on innovation is that not only about developing a new or advanced product, but also about creating meaningful value. And so this comes from it may come from new funding models, improved processes, identifying system gaps, or proposing practical solutions. And whether the product or an idea or innovation must improve the clinical pathway and existing systems and have a clear impact. So ultimately, the value created matters more than the novelty itself. And in some cases, even strong value can justify additional cost. Yeah, that was my last slide. So.
That was very, very quick. So thank you very much again for joining and for outlining the HTA and the governance processes at Medscheme. I think it was very insightful for most of the attendees on the call to understand what Medsscheme's expectations are from these kind of review processes, and also for us to understand as MedTech the expectations of timelines and what is expected from us to support Medscheme's review process. We have 2 questions in the chat already. So the first one is from, I think it's Lebo. Within the Medscheme HTA process, is there an opportunity to conduct pilot or real-world local evidence studies for new technologies from before a formal funding decision is made?
The answer is yes, there is. I mean, we will never say no. If you can come with a good proposal, but it must be comprehensive and well thought through. Then we will always look at the pilot idea. We work with different schemes, and it's usually here and there we've done things like that, but it's usually difficult or a challenge to get all your schemes on board for a pilot. So most of the time you will maybe get 1 or 2 that buy into that. And yeah, but it's doable, you know. But as I said, you have to present something that we can take to business for which a decision can be made.
Thank you,
And
Christine.
preferably it shouldn't add manual work, because what happens with pilots is that because you don't do it for all your schemes, yeah, it sometimes generate manual work. So if you also can look at that it doesn't, you know, make you now have to look at every case individually and take it out of your automation or your systemized process. But yeah, as I said, it's doable. It's not always easy, but it's doable, and you are most welcome to present any pilot ideas.
Okay. Thank you, Lebo. I hope it answered your question. The next question comes from Shelley Ann. Firstly, she thanks you very much for the presentation. For the cost offsets, may I ask over what sort of time horizons the cost and benefits are examined? My sense from the presentation is that return on investment is that this is done on a short time frame only, example within a year. Some technologies benefits cost offsets accrue over a longer period.
Yeah, it is a good question, because I mean, we can look at data quite far. Okay, maybe I say it also depends, because something you just want to know what it do in a year's time. You know, it's not necessary to have like a 5 or a 10 years. You just want to see was it effective. Because you usually will have, if there's a reoperation, you will usually have it within a year's time. If there's an infection, you will usually have it in 6 months, whatever. So I think you look at the technology to decide also what is the long-term data or the long-term follow-up that you want and to see in your data. But yeah, I mean, you can look at data over a longer period of time. It also depends on your type of scheme. You know, you've got schemes where people come and go, and then you've got schemes that where people's also over a long period of time there. But yeah, it is true. I mean, for most, we usually look at the shorter, and that's why we try to look then at what the international data says, because I mean, if there's a lot of studies or that shows that this over a 5 period of time that was the outcomes, then we also rely a lot on what internationally is happening if we don't have our data or don't look at our data. But yeah, it's true what you say. We don't always look over a long period of time, but we can if it's needed. I don't know if I answered the question.
Yes, I think you did. You got a thumbs up. So thank you, Christine. I know you have to rush off now to your next meeting. We appreciate you joining and sharing your insights. And I'm sure if anyone needs to reach out to you, they either have your details or they can use the details that was shared for the policy unit itself.
Yeah.
Or we can share that in the chat as well. So thank you again. Have a good day.
All right. Thank you for having me. Okay. Bye-bye.
Bye. So our last speaker for today is going to talk to us about the pre-launch of a HTA webinar series. And we have Dr. Tini Stander, who is a medical doctor, health economist, and strategist, with over 40 years of experience across the healthcare value chain. He is also the founder and managing director of Value in Research. So most of you all would have seen VI Research, and has led more than 250 health economic outcomes research and health technology assessment research projects internationally. His expertise spans over cost effectiveness, cost utility, budget impact modeling, pricing research, and health technology assessments. Today's session will help us think proactively before the launch rather than retrospectively. So the delegates or the attendees today will gain a deeper understanding of how HTA for medical devices differs from that of pharmaceuticals, practical guidance on planning and preparing for HTA submissions for medical scheme administrators, and strategic insights into building robust economic and clinical value propositions earlier. So it's a privilege to have you with us today, Dr. Tini Stander. It's over to you.
Thank you, Christine. Can I confirm that you hear me and that you can see my slides?
Yes, we can.
Thank you very much, and thank you for that kind introduction. I would want to ask my colleague Ilanka, who actually heads up our training and mentorship division in the company, to quickly introduce herself, because she will be part and parcel, and then I'll quickly take you through a few slides. Ilanka, if you could quickly just introduce yourself, please. Perfect, thank you.
Sure. Hi, Tini. I'm trying to switch on my camera. It won't let me. So just a quick introduction. Like Tini said, my name is Ilanka Fraser. I am the head of training and mentorship at VIR. I am the project lead for this HTA workshop for medical devices. I'll also be facilitating some of the sessions. I will also be your main point of contact for any queries or registration related matters. So I will pop my email address in the chat, and then please don't hesitate to contact me if you need any additional information after Tini's presentation, or any registration related assistance.
Ilanka, thank you very much for that. Yeah, thank you. I'm going to jump in immediately. I think my presentation is going to be the shortest. Thank you, Ilanka, for putting it together and applying your mind. And ultimately, we're talking about an inconvenient truth. If I think about life when I was a young doctor, it is so different compared to today. And I think the top line there is so accurate today. In your business, you are not selling products anymore. You are defending funding decisions. I think it's very unlikely that one will find good technology, not good innovation, but you need to defend funding. As we've heard from the previous speakers, from MedScheme as well as from the hospital, you need to defend that. And this is a completely different scenario compared to I was young. It is not just about clinical brilliance. It's very much towards affordability and ultimately value. And that's why our company is called Value in Research, because we know value is what drives the future and will drive the future. So this last, the bottom statement as well is that your task, if I could sum it up, is to make funding decisions easy for people who will pay. Your task is to empower people like Christine, who was the previous speaker, to make an easy funding decision, not to make it difficult. And this is what this workshop is about to explore. How do we make this funding decision as easy as possible? I'm not saying one can make it easy, but that's ultimately how you empower people like Christine to be able to make these decisions. And the other part of the inconvenient truth is this is not only for the private sector. So we're talking private sector predominantly today. The speakers were all from the private sector, but I can assure you, if we see what's happening in NHI and in the Department of Health in general, this will become as important and is becoming as important. And actually, I think in the public sector, it is the most important one if we take these two industries. The big game in town is the public sector. That's the one where some form of NHI will eventually take shape and where the majority of the funding will be sitting. So the winning equation here is whether you can quantify the clinical value of your innovation, the affordability, the feasibility of implementing it, and then the evidence plan. Those are the things that you want to be able to share. Now, one of the things that we've learned, and we've learned it the hard way in dealing with tech companies, with pharma companies as well, but more so with tech companies, is that from your launch to the ultimate funding decision, you get this drift. And this drift means that because the application process, the one like Christine mentioned, and she made some very practical remarks of the things that she sees happening. Every single mistake you make in your submission for reimbursement makes this drift become longer and longer. We've seen small little things, for instance, a submission of a HTA where the price of the technology was VAT exclusive, and when the funding decision came, there was a dispute that was not approved, but it's a mistake. Many other potential mistakes can be made and cause this drift. Now, there's importance, we know, as much as you know, time to market is critical. Time to market in terms of your own projections and sales figures is critical. So what we want to do very much in this workshop is to see whether we can support you and empower you to reduce this drift, to get it right first time. And again, Christine made some very practical remarks, which I fully concur with, of how this drift can actually become so long that your competitors launches a new innovation and they surpass you, and that's not what you want. And I think one needs to make this a little bit personal in asking these questions about a potential tomorrow. Do you know what the competitor reimbursement landscape is? Who are you competing against what price, what innovation? What is the value claim that you make? And is that value claim measurable? Is it quantifiable? Is it research-based, evidence-based, or is it hearsay? Do you have that evidence? Do you know the budget impact of displacing some old technology with your new technology? Do you understand the implementation story? Every device that gets approved does have a different potential workflow. There's an impact maybe on theatre and theatre time. She mentioned learning curve. There are many other elements in terms of that implementation plan. And what is your plan for uncertainty? So often, for example, there's uncertainty because many of your data points comes from a different territory, from first world country. And how do you defend that uncertainty? Can you be sure that if we see in the USA or in Europe, let's say, for instance, something like an auto transfusion system reduces cost by so much, and there's a percentage, can you assume that would be the same in South Africa? What about real-world data and real-world evidence? Do you have access to that, and to what extent can you use it? So what Elanca is planning with this, with these workshops then, is to almost provide some form of relief and to assist the participants to be prepared for a very, very uncertain environment. I can assure you, and I've listened to Christine and listening to the HTA process, it is fraught with challenges. It is not nearly as simple as HTA for pharmaceuticals. That is easy, simple, well-defined. Everybody knows in the world. Globally, wherever we've worked, whether it's the Middle East, in Europe, wherever, the maturity of the HTA processes for devices are extremely thin. Most of the regulators we've worked with in the past basically apply the same principles they apply for medicines. And that's simply not possible. It's absolutely not possible. So we want to make sure that you are globally grounded, yet you have multi-domain evidence and being able to translate value to a South African value story, manage the uncertainty and integrate it into your strategy of how you want to enter the market. Practically, the workshop is broken down in 6 workshops. We start with the why. And the why is actually very important. You know, most people tell us always start with the why. And one can listen to the med schemes of the world or the Life Health Hospital of the world, and you can say, you're just causing new problems for us. You're just wasting our money. You're just making it more difficult. I think the why part is important to understand to get into the boots of the other people, the people who actually will pay for your device, to understand why are they doing these things? Why are they putting these things as these barriers in front of you? Then secondly, to understand what is involved. What does it mean? What is HTA? I'm telling you, if I ask people across the world their definition of an HTA, it's as wide as the skies. So we need to bring that down to a concise definition and a sharing of minds of what we see as HTA as we go forwards. Number 3 is extremely important. I call it the Hexagon Challenge. There are 6, more than 6, but we will highlight 6 significant challenges which makes HTA for MedTech completely different to HTA for pharmaceuticals. And I can assure you, when you go to the forms that you need to fill in, the templates that you need to fill in, which is basically workshop 4, 5, and 6, you will see that these forms are not really designed for tech. A lot of these questions are extremely difficult to answer. I don't want to go into that detail. But this is then the structure, a little bit of almost a didactic part and then an interactive part. All of these sessions will be very interactive. These last 3 will be extremely practical, not about filling in a form, but how do you position yourself to reduce that drift? How do I get it right the first time? What can I do? What do I do with in the absence of data? Who do I talk to? Things like that. So the 3 were chosen, and it's not to criticize them. It's just because they're the biggest, and it's to help you to help them to make a better and a quicker decision. As I said, we want to reduce that drift. So it's ultimately, for us, it's a win-win that we create by presenting these subjects. From an operational perspective, understanding that you're busy, the workshops will be live, virtual, and scenario-based, very interactive. We will use our VI DigiEngage, which is a digital platform we use for interaction and data sharing. You will be, if you register, invited onto the DigiEngage. It's a single platform where all the workbooks, all the presentations, all the pre-reading, all the discussion questions will be hosted. It's a single platform which you can access. Ilanka prepares toolkits, checklists, and templates will be included. That will also be delivered there. And then there's a capped cohort, so we told Summit that for us to do this, and they pushed us very hard for discounts. Tanya, you will agree to that. But we have to have 40 people to make this worthwhile, basically to break even in this thing. So we are hoping to have 40 participants in this interaction, and then have very focused and concise discussions. I think if I ask myself if you can afford it not to attend, I do think in some cases there are companies, depending on your product portfolio, where it might not be beneficial at this stage to attend. I will agree to that. But then I think when you're in a competitive situation where price is not the issue, so let's say as a Arenes, price is not the issue. Price, it's a volumes game, it's not a margin game. But when you get to tech, for instance, many people talked about robotics today. Let's say things like ablation, cardiac ablation, valve replacement, auto transfusion systems, all of these kind of expensive yet highly impactful. I don't think you can afford not to be on top of this subject and to be prepared to become excellent in submitting HTAs. The one thing that I do want to mention, this workshop is focused on HTA for the payer. If we look at what Passmore presented, HTA for a hospital, it's a bit of an interesting one there, because the hospital might be the payer, but the hospital might not be the payer. The medical scheme might be the payer. So we are focusing on the funder of healthcare, which is the medical scheme, and that's why we have those. We're not focusing on HTA for the hospital groups. That's basically. So thank you very much. That's all from my side. I told you it's going to be quick, and Christine, if there are any questions, we are happy to, Ilanka and I are happy to answer.
Dr. Stander and Ilanka, I think your presentation has been clearly outlined the need for for this kind of preparation, considering the competitive market that we have and the changes within the healthcare system in South Africa. And what you've outlined from the workshop, it seems like it'll provide our attendees with an insightful look at the information and expectations as a guideline to what the local schemes require and what's needed from our side as MedTech. And it also is more of a practical, I would say, workshop focusing on the realistic challenges that we experience as MedTech in South Africa. We do have questions now, and the first one is from Tanya.
Thanks. Thanks, Timmy and the Value and Research team. I just want to mention to the members that this course has been quite long in the making. We've had a number of engagements with Timmy. The committee, the Market Access Committee at SAMED, has been intricately involved in helping to design the course and making sure that it's fit for purpose. As Timmy mentioned, we really did negotiate Timmy down. There are these tiered costings and significant discounted rates for SAMED members. However, we can only do this if we have a minimum of 40 participants. So my question to you is, Timmy, how will we manage that? Do you have some ideas? We just want to be clear on the process. If members are keen and interested, they contact you directly, and then, will we be periodically updating? I think we should, the members in terms of the numbers, because I imagine there would also need to be a cutoff point. If we don't get the 40 by a certain period, then we're going to have to say, well, we can't continue with this. Please note it's not limited to SAMED members. Non-members can also participate, but at a higher fee.
I'm going to ask Ilanka to answer that. She will manage that with the admin team, but Ilanka, if you have any thoughts on that.
Yeah. So Tanya, you're correct in saying that we need to have 40 participants at minimum to continue. So I shared the marketing blurb or the infographic with your team. I believe that has been posted in the newsletter. It will be shared with your members on WhatsApp, on the WhatsApp groups, I believe. Also LinkedIn. So there is a QR code for access to the registration form. So members can then register by scanning the QR code. I might also, and on the SAMED website, I see, thanks, Tanya. And then I will be tracking the registrations. So we will only be sending out invoices once we have cohort confirmation. So once we have 40 participants or more, then we will only start invoicing. And then we will then also agree that we continue and set a date for the first workshop. And then please just everybody check the terms and conditions, because once cohort confirmation has been done, it becomes non-refundable, unfortunately. So just to make sure that there are some terms and conditions in the registration forms, but also if there's any queries, you can reach out to me directly and I will assist.
I just have a question from my side. So when are you all expecting to start rolling out with your first workshop? So it also gives some idea on timelines.
Well, it depends on how quickly the registrations come in, but I think the plan was towards the end of March, beginning of April for the first workshop, and then it will be once a month after that.
Okay. Is there any other questions? The floor is open.
I think it's in the blurb, Ilanka, just a little bit of detail. So the 6 workshops are 90 minutes each. and we'll organize it in a time space which is appropriate for most people. And there will be, in some cases, pre-reading material and preparation to be done. So I think people can anticipate to spend 1.5 hours in the workshop, and maybe half an hour, on average, half an hour preparation time. Ilanka, would you agree with that?
Yes, that's correct.
Okay.
Okay, so just comments from the chat. Tanya said that it's also available on the SAMED website. So if anyone wants to check it out, you can go onto the website. And Shirley Ann, thanks you very much, Chini, for the presentation. I want to know if you're in Dubai, are you safe?
Sorry, say again?
He wants to know if you're in Dubai at the moment.
Fortunately not. I
Okay.
tell people I was at Bangbroek. You know what a Bangbroek is? It's an Afrikaanse Banggat. I was scared to go there. I was supposed to be there, and I said, no, this war seems to be hectic. I'm not going there. So now I'm very happy I stayed home.
So you're lucky. Yeah, I'd rather
Yeah.
be close to family. Tanya
Yeah.
has another question.
So that means no more Teams calls. Tini, we have to see you in person when we meet again. No. I don't think the information is yet on the SAMED website. Nomti can confirm that, but we will put it on the market access page and also under news so that members can find it easily under the category market access. Okay, so yeah.
Perfect. If there's no other questions, this brings us to the end of today's Market Access Forum. So thank you very much, Tini and Ilanka, again for the presentation. And we look forward as well to, starting that workshop and moving forward and in I would say, educating and making everyone knowledgeable about HTAs and the processes. So thank you very much again. We also
Thank you.
have. Thank you. So on the screen, you will see there's some upcoming forums that's dated, and you will be also getting correspondence via email. So we have a few that will be coming up in March until the end of March for the Diversity and Inclusion Forum on the 10th, and the Women in MedTech Forum also on the 10th. And then we have on the 11th, the Market Access Forum, which would be a part 2. 17th of March is a Market Sustainability Forum. 24th of March, Regulatory Forum, and 31st of March is the NHI Forum. So there's quite a bit happening, and I know everyone's calendars are quite busy, but please do make time to join these sessions because they can be very, very informative, and they can help you within your role at your company. So again, thank you very much to all our presenters today. We had Carrie Ann from Council of Medical Schemes, Pascal from Life Healthcare, Christine from MedScheme, and Dr. Stander from VI Research, for sharing your expertise and for engaging with us so openly with our members. And then today's message, or to leave you with the message for today, is that data shapes policy, policy shapes funding, and funding shapes market access. So if we want to compete, we need to understand the system and not just our products. So thank you to all the delegates for your participation and for your questions. And if you have any questions or queries or even any suggestions for future topics, please send them through to Nomti. And as I said, the communication around the workshop, which is a very important workshop in my opinion, will be going out soon, and it's available to SAMED members and non-SAMED members. Yes, Tanya.
Thanks. Christine, can I just add to the members, please, as you engage with the hospital groups or with the medical schemes, and if you are experiencing challenges or you don't understand something in terms of their process, please won't you send us those queries or concerns. We recently had a meeting with Discovery and they're keen to hear what the members' concerns or, challenges and even confusion is around their processes, both the PIN and the HTA processes. And they asked us to package those and send them to them with a view to potentially offer some workshops or add to guidance documents or even create guidance documents for industry. So please, send me those queries and concerns and challenges. I'm committing to also engage with Life further around their categorization and their HTA processes and see, what those are in more detail.
Thank you, Tanya. So thank you to everyone and have a good day. Bye.
Thank you, Christine, for
Pleasure.
moderating.
Thanks, everyone.